according to the KDIGO guidelines. Okay,
Yes,
so then if it all in ICU session or in any scoring systems, now they'll ask about the rifle criteria, Akin criteria, and KDIGO. So we must know about this. How do you say about rifle? What is Akin and what is KDIGO? So can anyone of you come up with what is rifle criteria?
Madam, the screen is showing.
Yeah, no problem. That is like for anyone who doesn't know to just revise. That is why I make up these PPTs so that whoever doesn't know will actually know it at least from seeing the presentation. So this is very important in pertaining to ICU session where they'll ask about, I've told it earlier also, regarding the scoring system. So even at least basically, can anyone say what's a rifle criteria? You've got 9 participants. Yeah.
It's yes. R for risk, injury, failure, loss, and disease.
Okay.
The risk is if there is more than 1.5-fold increase in the baseline creatinine or decrease in GFR more than 25%.
Okay.
Then the injury, it is more than 2-fold increase from the baseline CFR and decrease in GFR more than 50%. Then the failure, more than 3-fold increase in the baseline creatinine and more decrease in GFR more than 75%. Then there is this loss. This is more than
a persistent acute
persistent loss for more than 3 weeks.
For 4 weeks.
For 4 weeks, yes.
4 weeks.
4 weeks.
Then
And stage patient less than GFR less than 15 ml. And patient requiring this renal replacement therapy.
Yes. So what are the causes of renal failure? May it be chronic renal failure or acute renal failure. What are the causes of renal failure?
Renal failure causes can be divided into pre-renal, renal, and post-renal.
Yeah.
Pre-renal causes are hypotension.
Yes. Pre-renal cause, yes. Hypotension.
Sustained hypotension.
Yes.
Hypoxemia.
Hypoxemia. Okay.
Renal hypoxia. Sorry, renal hypoxia.
Anywhere where there is hypovolemia, low cardiac output states like in cardiorenal syndrome induced AKI. So SOPs and whenever there is a renal artery, inadequate blood flow to the renal blood vessels. So hypovolemia is the primary cause. And what are the renal causes? Example for
renal causes, madam, they could be glomerular or either it could be IG-induced nephropathy, focal glomerulonephritis, membranoproliferative
tubules, or anything which involves the glomerulus, as I said, tubular necrosis or glomerulonephritis, focal segmental glomerulonephritis, all that. And the post-renal cause?
Obstructive uropathy.
Okay, obstructive uropathy. Anything down the...
And yes, madam, and pyelonephritis reflexing into the kidneys.
Okay. Then any ureteric stones or bladder obstruction or a prostate which is obstructing or a tumor, all those will cause a post-renal failure. So we'll discuss regarding a case scenario. I think it's not clear. Just a moment. Just a second. Yeah, okay. It's clear now. So can you read up this case scenario? Yes, and discuss about how will you proceed?
Yes, madam. A 60-year-old diabetic hypertensive CKD patient posted for obstructed hernia repair. He is on regular hemodialysis twice a week and last had dialysis 2 days prior.
Sorry, thrice a week, not twice a week, thrice a week.
Okay, here it's written twice a week.
Yeah, thrice a week.
Fine. How will you evaluate and manage this patient? What are the concerns in CKD patients?
Yeah.
We'll start with the with a general physical examination and history, specific history regarding renal, regarding CKD would include history of any causes, onset, how long back was he put on renal replacement therapy? Was it an elective decision or was it done as an emergency? Had there been any complications during the renal replacement therapy? And when was the what is the patient's weight before and after the dialysis? When we know it was done 2 days prior, so what was his weight 2 days before the 2 days back before the dialysis, and what's the current weight? We would also assess for state of hydration, for facial puffiness, pedal edema, urine output, whether the patient has some native urine output or not. What medicines is the patient taking? Does the patient have any comorbidities like diabetes,
No,
coronary artery disease?
He already has diabetes and hypertension.
Hypertension. Okay. So maybe any history suggestive of the patient having a coronary artery disease.
Okay.
Then we would, then I would carry out a general physical examination, including his blood pressure. Respiratory problems like pleural effusion has to be seen. Maybe there is ascites. It has to be assessed. What's the respiratory rate of the patient? Is the patient having any respiratory distress? Was the what medicines is the patient taking?
Okay.
How has been the blood sugar control? Then then investigations. Investigations would include a CVC, kidney function test, including electrolytes, ECG, chest X-ray, echocardiogram, urine routine test, urine microscopy, and patient's temperature has to be checked.
Okay.
Whether patient has some infection going on.
Okay.
Echocardiography also would be required.
Okay.
And coagulation profile also is to be ordered and checked.
Okay.
If the patient is not in a grossly hyperdynamic, high cardiac output state, and coagulation profile is all right, patient can be managed with a regional anesthesia.
Okay.
If patient is taking ARBs, they need to be stopped. Rest of the medicines can be continued. If the patient is taking insulin,
okay, we'll stop here. Anyone who wants to add up in the history or examination, any further things you want to look for, because some of you volunteered for CKD also, no? So if any point you would like to add.
Yes, ma'am. First, we would like to discuss with the surgeon that whether it's a dire emergency or he can wait for a few hours as it is obstructed hernia. Then this is thrice a week, so every other day he's on dialysis. Yes. So he had dialysis 2 days prior. So maybe he was just to go dialysis in the next day only. So we'll discuss with the, we'll assess this fluid electrolyte and acid-base status. Most important is potassium and this acidosis. We need to rule out and discuss with the nephrologist whether we can proceed without dialysis, or patient need dialysis before we'll take the patient to the OT. Means our goal is to optimize the medical condition and before taking the patient to OT.
Okay, so the thing is, we assume that the examiner knows. So whenever they ask such questions, how will you evaluate? You start from the history of the patient. Since because the discussion is towards CKD, our eyes focused only on CKD. So you in the history itself, there is the history of obstructed hernia. So you should ask about what is the symptom which has brought him to the hospital, like how many days has he been having pain, or what is the symptom he had, does he have fever or any other symptoms like vomiting when there is an obstruction down. So all these must be evaluated. What is the presenting complaint, one should not forget when they say how will you evaluate. Okay, so and then even when we ask, we should actually tell the history of previous surgeries, any allergies, and what was the previous anesthetic technique about. And in the examination, as sir said, look for the volume overload, and all the general vitals must be told. When we say it is evaluation, it is like evaluation of everything. You see the patient as a whole, then you say about the medication history, what he's on for diabetes, what he's on for hypertension, and as sir has mentioned about dry weight, and had he had any complications. And in the examination, in the CKD patient, we do not forget about the position of AV fistula.
Yes.
So in which hand the AV fistula is there? Is it patent? Has there been any change of a fistula recently? And all that, because this case is an emergency, still looking for AV fistula and all the vital signs. And airway examination also is a must. Airway, spine. Okay, we should not forget all these, because we have just jumped from evaluation to management. So of course, discussion with this nephrologist is fine. And as you said, looking for potassium and ABG is also fine, because they will have acidosis, and since it's an obstruction, we treat it as an emergency and take. So what is one parameter which says about the bleeding situation of a patient with CKD?
Bleeding time.
Yeah, bleeding time. So what are your concerns in this patient, because he's a chronic kidney disease patient? What are the concerns, or what are the...
There may be platelet count may be normal, but there is platelet, qualitative platelet dysfunction.
Yeah. Okay. So, yeah. What are the various systems which are affected in chronic kidney disease patients?
Well, so many systems are affected. The effect on it has effect on by decreased production of on cardiovascular system, because of the decreased production of erythropoietin. There is anemia. There is also anemia is also caused by destruction of RBCs during dialysis, as well as uremia decreases, shortens the life of the RBCs. And there are associated nutritional deficiencies like folate and B12. And there may
what
be...
is the type of anemia in chronic kidney disease?
Normocytic pneumochromic.
Okay.
So these patients are anemic. They are hypervolemic. They have uremic cardiomyopathy, atherosclerosis, higher chances of associated coronary artery disease and other systemic atherosclerosis. However, because of the anemia, the blood viscosity decreases, and because of the chronic anemia and acidosis, this compensatory change, there are compensatory changes like increase in 2,3 DPG levels, and which shifts the oxygen dissociation curve to the right, and the acidosis also shifts the curve to the right, so they tolerate anemia better. In the respiratory system, the patient may have fluid overload, may have pleural effusion because of presence of more than normal fluid in the lungs. Gas exchange may be impeded.
Okay.
The GI system patient may have bleed, nausea, vomiting, anorexia. Patient because of chronic acidosis, there is bone resorption, secondary hyperparathyroidism, hyperkalemia, hypocalcemia, hyperphosphatemia, and
in immune system, they are more prone for infections, and in neurological system, they are actually more prone for distal symmetrical motor and sensory neuropathy. Hello?
And on the central nervous system, there's encephalopathy, peripheral polyneuropathy.
Yeah. The polyneuropathy is distal symmetrical motor and sensory polyneuropathy. Okay.
And, there can be tremors, seizures.
Okay. Can you tell me what are the specific serious effects of chronic kidney disease? As you had already told, it is about accelerated atherosclerosis. That is fine. One thing we should not forget is ischemic heart disease, hypertension. So hypertension itself can cause CKD, and CKD itself will precipitate hypertension and congestive cardiac failure. Okay. Sumaira ma'am, can you please mute yourself? Sumaira ma'am? Yeah, thank you. So, what are the concerns while using the drugs when you have chronic kidney disease? Sir, yet another sir volunteered, no? Sir, can I ask him, like, if he's
Sure,
okay?
Sure.
Yeah. Yeah. Sir?
Yeah,
Dr. Dayana.
Yes, ma'am.
Yeah,
Yes,
yeah, yeah.
I'm here.
Daya sir, I'm sorry. Yeah.
Yes, ma'am. So, as far as CKD is concerned, so the drugs which are eliminated by the kidneys, this metabolism of the this CKD will have effect on pharmacokinetic and pharmacodynamics of the drugs, which we routinely use in our anesthesia. And other drugs which patient may be already on while having CKD, maybe he is on diuretics and erythropoietin.
Okay.
And so, as far as anesthesia drugs are concerned, so we'll start with this pre-medications. We are using benzodiazepines. So these are, we need to decrease the dose of benzodiazepines when we are using in the CKD patients. Then the induction agents, propofol and etomidate, and ketamine, these are minimally affected. And barbiturates, because of the decreased protein binding and because of acidosis, the ionized fraction is increased. So patients are more sensitive to the barbiturates, and for the same reason to benzodiazepines also.
Okay.
Then if you think of this anticholinergic drugs, though atropine and glycopyrrolate are minimally affected, but on repeated uses, they may cause accumulation in the patient of CKD. Okay. Then if we'll go with this H2 receptor blocker and this metoclopramide, they also get accumulated on repeated doses. Single doses are minimally affected. Okay. Then we'll think of volatiles. Volatiles are safe in patient of CKD. There is one concern about compound A if we use sevoflurane, but studies have not shown any effect in humans till now. Okay. And then we'll think of this opioids, this fentanyl, sufentanil, this remifentanil. These are minimally affected, but we should reduce the dose and give them slowly. We should avoid morphine because its metabolite morphine 6-gluconate that gets accumulated, and mepridine because normepridine, its metabolite that cause seizures.
Okay.
Yeah. Then
so, but,
yes, ma'am.
Yeah, finish it off, please.
Then if we'll think of this anticholinesterase drugs, this neostigmine, it is eliminated by the renal. So there are chances of recurrentization in the post-op period. So we need to be cautious in the post-op period. These are the concern as far as anesthetic drugs are concerned. And if we think of this, this diuretics, so we need to see the fluid and these electrolytes specifically before in the pre-evaluation.
Okay. You had mentioned that remifentanil, we need to adjust the dose. But remifentanil undergoes ester hydrolysis and it can be safely used. Like we have a precise control over both onset and offset with remifentanil because of the ester hydrolysis. And you practically covered everything. And one more thing we should not forget is NSAIDs we should not use in the perioperative period.
NSAIDs are contraindicated. And all nephrotoxic drugs like the SAIDs, aminoglycosides, or this radio contrast agents, we should avoid this.
But these are the patients who can be who are on CKD, but they actually have they poor urine output. But then if the patient is totally on CKD, then CKD on dialysis, then the scenario may be different. And another thing is local anesthetics actually like bupivacainol, it's only 5 to 10% eliminated via kidneys, and dose adjustments for them is not necessary in case of local anesthetic. So
they say that maximum dose of local anesthetic that should be decreased by 25% in case of CKD patients.
But the bupivacaine totally is like only 5 to 10% excreted via urine. So So 20 minutes over. So I don't know really who volunteered for the perioperative arrhythmia. Can you please come? Okay. Anyone can actually can try this question if the volunteer is not ready. Okay. So periop arrhythmias. Yashoda ma'am. Yashodaya.
Ma'am, hi ma'am.
Yeah. Can you try this question? So all are perioperative arrhythmias. Okay, he's a 66-year-old diabetic, hypertensive, chronic coronary artery disease patient. He's on beta blockers, diuretics, and OHAs. Who is undergoing a laparoscopic hernia repair. Intraoperatively, you get this rhythm. So, what is your management of action? The patient is hemodynamically stable.
Okay.
Okay.
First, we should make sure that the patient is adequately ventilated and oxygenated.
Yes.
And we should look for any causes of intraop arrhythmias like hypoxia, hypercarbia, hypothermia, or acidosis, or electrolyte imbalance.
Yes.
As the patient is already a known patient of coronary artery disease.
Are you able to see the
There are ectopics in the ECG.
Yeah, this is actually a bigeminal.
Yeah.
Okay. So you have said what will you do? You have checked for everything. Then how will you treat or what will you do?
Yeah, if the patient is hemodynamically stable, we should look for any underlying cause and try to treat it.
Okay. Any drug Any specific you want to administer? Able to hear me right now?
Yeah, yes, ma'am.
Yeah. Any ventricular premature complexes, what is your go-to drug?
Xylocord.
Lignocaine.
Yes.
Yeah.
Xylocord. I mean, it's not like plain
Yeah.
Xylocaine. You just tell me what is the dose you will give and how will you. That's all.
Okay.
So, is that fine? Anyone else who volunteered?
IV Xylocord preparation, IV lignocaine
Yeah.
preparation,
Yeah.
1.5 mg per kg.
Yeah, 1.5 mg per kg. So, since the patient is hemodynamically stable, as and when you were loading Xylocord, the patient developed this rhythm. So, just a second. The patient developed this rhythm, and his BP is somewhere around again 100/60. So, you are yet to give Xylocord. Now, how will you manage?
Now
This is
there is a run of
again a ventricular premature complex, but it's a couplet.
Yeah.
Yeah.
couplet. So the patient is now deteriorating hemodynamically.
No, hemodynamically still he's stable.
But the BP has dropped to 100/60.
Yeah, his pre-op also was around 100/60. He's not hemodynamically deteriorated.
Okay. So then of course we'll administer the IV Xylocord, and
Okay.
then we'll check if it has improved or not.
I'm not able to hear you, sir.
We'll administer the Xylocord
Yes.
because we were yet to administer it. Then after giving IV Xylocord, we'll check if it has responded to the IV drug. The rhythm has responded to it or
Yeah,
not.
but after you have administered Xylocord, the patient has developed this rhythm.
Now the patient has gone
The
into
patient went into
ventricular tachycardia.
Yes.
Now we'll auscultate, like we'll palpate the carotid pulse, and we'll see and check the vitals. If the patient is hemodynamically stable and we can palpate the carotid, then the patient is having a ventricular tachycardia, and we'll administer. We'll try to revert it pharmacologically through Amiodarone. We can use Amiodarone. But if the patient has deteriorated in terms of vitals hemodynamically, then we'll revert it. We'll cardiovert it basically. And if there is no carotid pulse, we'll start with the ACLS protocol.
Okay. So what is the indication of high quality CPR?
So the high quality of CPR indications are patient is unresponsive. Now the patient is already
No. What are
GA.
the steps by which you know, or like how will you give the chest compressions like that?
Okay. What is high quality CPR you're asking? Yeah. So the high quality CPR has got like, first of all, we have to push hard and push fast. Push hard.
Yes.
Push fast means compression rate should be 100 to 120 per minute. Then depth should be 2.5 inches or 5 centimeters in adults. Then we have to start the chest compression within 10 seconds of identification of arrest. Then we have to give minimum interruptions in between. Then we have to give effective ventilation within each second. Now the patient is already intubated. We have to give 10 continuous ventilation of 10 per minute, and we have to check that we don't over ventilate the patient. These are the components of hypertension.
Okay.
And adequate chest recoil also in between.
Yes. Well, you have intubated and there is an end-tidal carbon dioxide monitor. So what is the end-tidal carbon dioxide you are aiming for when you have a high quality CPR?
So we aim for EtCO2 of more than 20 mmHg. More than 10 mmHg. And if we got EtCO2 more than 20, then we consider that the patient may have achieved ROS.
Okay. In the same rhythm, So assume that the patient is a known diabetic hypertensive. He has got an infected wound with the nil urine output for around say 6 hours. And during the procedure, you have taken the investigation, but the investigations are still not out. Since because he is an impending septic shock, you have given a peripheral nerve blockade and you have taken the patient up. And intraoperatively, the patient develops this rhythm. And then the potassium comes as 7.2. So what is your what is the way of action?
So if the patient now the patient has got deteriorated hemodynamically, and the patient has got a hyperkalemia, so we'll first start with the
Yashoda madam, you want to try? Deepak sir, shall I ask Yashoda ma'am because she volunteered? Yes.
Okay, ma'am. First we start with ABC, airway, breathing, and circulation. First we try to intubate.
No. I have not mentioned whether the patient is hemodynamically stable or not. So that is, you should a VT can be stable VT or an unstable VT, isn't it? So you say that I'll see for the pulse. If the patient is hemodynamically okay, then you continue. Yes, you continue. I should not continue. Yes.
Okay.
Okay.
If the patient is hemodynamically okay, if he ends up with having ventricular tachycardia, then pharmacological intervention is needed.
Okay. No. I told you the scenario. I mean, did you hear the scenario?
Yeah, I heard the scenario, ma'am. Patient has no urine output and patient is infected with
then you continue.
Potassium of 7.5 millimoles. So
to
bring down the potassium, first we should stabilize the myocardium by giving it a IV calcium gluconate 10%.
Okay.
And then we should give glucose plus insulin infusion.
Yes.
50 ml of 50% dextrose with 10 units of insulin. And if the patient is in metabolic acidosis, we can try sodium bicarb and salbutamol inhalation.
Okay. So once when you stabilize,
hyperventilate the patient.
Hyperventilate the patient.
Yeah, I mean, I said it is like under a nerve block, so I didn't go into that. Okay. So the next scenario is he's a 72 years old male, hypertension, a known chronic obstructive pulmonary disease. He has got a left foot wound. So you have given a popliteal sciatic block, and intraoperatively he developed a hemodynamically stable rhythm. So he's got all risk factors: a septic wound, and he's a COPD, and he developed this rhythm. He's hemodynamically stable.
Patient is in atrial fibrillation.
Yes.
So we should try to find out the underlying cause as the patient is infected. Sepsis may cause atrial fibrillation.
Sepsis with a background of COPD, it can trigger, obviously. Yeah. Okay. No, you've seen this rhythm. It is all about treatment of the rhythm. No, he is hemodynamically stable. It is all about treatment of this rhythm. Anyone who wants to try?
Yeah. So this patient has got developed the rhythm of atrial fibrillation with fast ventricular rate. And as you said, the patient is hemodynamically stable. So we'll try to revert it pharmacologically. So we'll start with this amidaron.
Yes.
The dose of amidaron we'll use is 150 milligrams IV bolus, followed by 30.
Mr. Car, I think. Can you please mute yourself? I'm not able to find any name. It just says A Car. Yes, sir. Please continue.
So, after a bolus of 150 milligrams IV in over 10 minutes, we'll start with the infusion.
Okay. Hello.
Oh, sorry, I got muted. I don't know why. So after the initial bolus of 150 milligram IV, we start the infusion with 60 milligrams per hour over 6 hours first, then 30 milligrams per hour over next 14 hours. 8 hours and 14 hours. 18
for
hours.
6 hours, 18 hours. Yashodhya,
Yeah,
madam,
18 hours.
would you like to continue? If the patient is hemodynamically unstable, what is your mechanism of action, or what is your course of action?
If the patient is hemodynamically unstable, we should give electrocardioversion.
Yes.
First, we should make sure that the patient is, we should see all ABCs, airway, breathing, and circulation.
Yes.
And we should start defibrillation of the patient.
No, the patient is wide awake.
Wide awake.
No, he's wide awake. No, he's just a 72 years old man who is undergoing under a popliteal sciatic block. So he's awake and he's hemodynamically unstable. So you cannot cardiovert an awake patient just like that.
Yes, yes.
So whenever you say
sedate him
this,
first.
yeah, this is what is
Sedate.
most important. So whenever you say the
Yeah.
treatment, you say as if you will treat the patient like how you do routinely. Okay.
Okay.
Okay. So you have what will you sedate with, or what will you give at that time?
Midazolam.
Midazolam and fentanyl.
Fentanyl is fine.
Fentanyl.
Fentanyl is fine, or etomidate is fine. Like whatever. Then so what will you do? Will you cardiovert or will you defibrillate?
Cardiovert.
Cardiovert. What is the dose you will use for cardio? It is not like you just say I'll cardiovert this. I will cardiovert with this synchronized this with this much joules after sedating the patient with this. You will stop there. Okay. So come on, anyone.
After sedating the patient, I will cardiovert the patient with biphasic.
Yes.
Biphasic energy of 200 joules.
No, 50 joules.
50 to 100 joules.
Yeah. So you start initially with lower dose. If it's an SVT, it's definitely 15 joules. So if at all the rhythm is an SVT, what will you, if the patient is hemodynamically stable, what will you do?
If the patient is hemodynamically stable,
yes.
And if he is awake, we can try for Valsalva maneuver or
yes,
vagal maneuvers like carotid massage and all.
Okay.
Or pharmacological interventions like amiodarone.
Yes, for SVT.
Adenosine.
For SVT, we can use
adenosine.
Just lignocaine. If the lignocaine is not used, then adenosine. Yeah, and if the patient has asthma, then we can go for verapamil.
No. Let's see. If it is an SVT, according to ACLS guidelines, you say it is adenosine 6 milligram IV push. If it is not responding, then followed by another 6. Okay. So for SVT, it is adenosine. For amiodarone, you can use. For AF, you can very well use amiodarone. Okay. So for ACLS protocol, when it is an when it is a VT and when it is not responding, you say amiodarone 300 milligram bolus. Okay.
Okay.
Not 150 milligram. When it is a VT, unstable VT, when you are shocking, amiodarone dose is around 300 milligrams. But it is a VT with the pulse, then you give amiodarone 150 milligrams. Okay. Amiodarone 150 milligrams 10 minutes, you give it as a bolus. Then you give 1 milligram per minute for at least first 6 hours for a VT which is with the pulse. In case of like stable VT. Okay. So the next case scenario is
ma'am, I got a question. Can I ask? In UK practice, during AF management, they actually use flecainide rather than amiodarone. So should we say flecainide or amiodarone?
Here we are using only amiodarone, and we have not seen flecainide at all. So I have said amiodarone, and they were quite okay with it because we are routinely using amiodarone only here. If you find any protocol,
in Southeast Asia hospitals, we always use amiodarone.
But
in UK, but in UK practice and UK and European country, they usually use flecainide. I have seen it. I have observed it. They use flecainide. So should we say flecainide or amiodarone in that case?
Is fine because I mean, even in ACLS guidelines, no, they have given procainamide, but we have never seen procainamide in our life. So we continue to say amiodarone. And in my Viva session, I said amiodarone, and they were quite okay with it, madam.
Okay, fine.
Okay.
Thank you. Thank you very
Okay.
much.
Okay, so I think we have got only 5 minutes left, so we'll rush through this rhythm. So he's a 30-year-old male patient who has gone undergoing a laparoscopic umbilical hernia repair. Upon inflation of carbon dioxide, patient developed this rhythm. How will you manage? Anyone?
We will
The sinus
look for
radical.
airway breathing circulation,
Yes.
and we will.
No, this rhythm developed basically
This
after.
rhythm is sinus bradycardia.
Yes.
And
Sinus bradycardia.
so this rhythm is because of carbon dioxide insufficiency. So we'll just ask the surgeon to deflate the
Yes.
stomach, first of all.
Yeah. Then
And
you
if
ask them to.
it will not respond to that deflation, then we'll give atropine push, 0.6 milligrams.
Okay. Okay. So that is the answer I was expecting for. So you deflate the abdomen. Then you ask the surgeon to re-inflate the abdomen slowly once when the rhythm settles, and ask them to keep the inflation pressure slow. That's all. Okay.
Yeah.
Yeah. Then next case scenario is a 40-year-old male patient with like known CAD who is undergoing a laparoscopic anterior resection. So known inferior wall MI patient, and intraoperatively he developed this rhythm. How will we manage?
This is heart block.
Yes. What heart block?
Third degree.
Even in ECG sessions, you will be given ECG like this. And in
This
my
is
session,
complete
I
heart
was-
block, ma'am.
THB.
This is complete heart block.
Complete heart block. The P doesn't
Because
coexist with the QRS.
This is
Yeah,
complete heart block.
I
So
have given
we'll
the
have
clue
to-
in the question itself. It's an inferior wall MI. Already known inferior wall MI on medical management. So that correlates, right? It's a complete heart block.
We'll have to put the patient on the pacemaker.
Pacing.
Till the pacemaker is available, we can give patient isoflurane.
Okay. See, again, you now ask for whether the patient is hemodynamically stable or unstable. And of course, pacing is the treatment of choice. They may ask about what do you know about transcutaneous pacing?
Yeah, transcutaneous patient. Yeah, we can use that.
Yes, transcutaneous pacing, anyone?
Pardon? Didn't get you.
Transcutaneous pacing. I'm not audible. I said transcutaneous pacing.
Yeah.
Transcutaneous pacing.
Yeah. So transcutaneous pacing can be done now the modern
Because in the
defibrillator
midst of the
machines have got a-
surgery, you cannot actually go and intervene, like ask for a cardiologist and say like, it's okay, it can happen. For a transvenous pacing, it can happen. But if you're having a defibrillator nearby and a transcutaneous pacer, they may ask, how do you pace a patient in a transcutaneous pacing?
So transcutaneous pacing, yeah. Although I haven't used it, but all the modern defibrillators now have got transcutaneous pacing facility. So we'll attach the pad, and then we'll pace the patient as per the parameters. Like we have to set the trigger and set the rate on that.
Okay.
machine.
Okay. Anyone who want to attempt this question? Transcutaneous pacing? How will the pads be kept?
Pad will be one pad will be below the right clavicle, and
Yes.
another will be at the apex of and this on the left side at the nipple.
Yes. Okay. So what is the pacer output you will set?
We usually set around 70 to 90 a minute.
Okay, pacer output can be 60 milliamperes, and then you can increase. So if the patient has confirmed the capture, like the patient is capturing the rhythm. Okay, so just a second, I'll just share my screen so that you can also see. So if the patient is capturing the rhythm, means then you can actually from that you have to increase the 10 milliamperes and keep. Okay, able to see? So you attach the pads either in the, because it's a lap anterior section, you can always have this anterior chest lead pads, and you can set the pacing mode and rate. And if the 60 milliamperes, from that you have to increase the current and you have to confirm the capture, and you have to set the pacer output 10 milliamperes above the capture. Okay.
Yes, sir.
So one should not forget, you have to turn the mode to a pacer mode in the defibrillator.
Yes.
Okay. So this they may ask in the intraoperative rhythm type of question. And if at all you get a question like, I got a question scenario for that hyperkalemia. So as you have told only, I also told. They gave me a scenario and asked for if the patient, all that. But then the initial point one should not forget is the patient is developing an arrest. At all point, whenever the patient develops an arrest, you say, I'll call for help. That is the first point they expect, like you were called for help, or will you call for help? So you say, yes, I recognize the rhythm, I'll call for help from the next operation theater or from my senior, and then I will proceed with so and so. In the interim, I'll call for help, like that. Okay. And whenever you're given any liver disease or renal disease, please do not focus on that particular aspect alone. I put it only because we'll always have the thought of noting that particular system only. See the patient as a whole. Ask for any preoperatively, and whenever you see podcast also, they would have given from the start, examine the patient as a whole for all the systems. And you will say, I look for this because he is a CKD. Like whenever they ask, you can tell what are you looking for. And in any examination, please do not forget about airway, IV cannula assessment, or an intravenous placement assessment, or spine assessment. But we may fail to say, which will cost us very bad than the assessment of CKD. Okay. And in the intraoperative arrhythmias, which I have not told is first degree AV block, usually that is not going to have any impact in the hemodynamic this thing, and it will just resolve. And if at all they are asking about second degree heart block, type 1 is actually quite benign, and type 2 they may need pacing, like depending upon the scenario, like how is the patient's hemodynamics and all that, and what is the cause which has caused. And type 3 I have discussed. And one more rhythm is sinus tachycardia. You will always see for what are the causes of rule out. You will rule out the causes for sinus tachycardia. So anyone, can you tell about what are the causes for sinus tachycardia intraoperatively?
Pain, anxiety.
Inadequate.
Yes. Yes.
Hypercarbia.
Inadequate anesthesia, inadequate
Yes.
analgesia.
Yes. Yes.
Electrolyte.
Yes.
Thyrotoxicosis.
Yes. Still.
Malignant hyperthermia.
Yes. And causes for intraoperative bradycardia? Bradycardia?
It is bradycardia mainly due to surgical stimulation, like oculocardiac reflex and anorectal examination, cervical dilatation, laparoscopic surgeries.
Yes.
And administration of scoline, succinylcholine scoline.
Yes. And Cushing's reflex as well. Okay, Cushing's reflex as well. And Bechor-George Cushing's reflex. Okay. And so any patient who is on beta blocker, what is sinus bradycardia? And then any patient who is on beta blocker, what is sinus bradycardia? And then less than 50.
Can you repeat your question?
Any patient who is on beta blocker, what is their range for sinus bradycardia?
Okay.
Less than 50.
Less than 50. And any patient, any adult patient, what is the rate below which even a healthy adult do not tolerate?
45.
40. Okay. And all the electrolyte disturbance also can cause either a bradyarrhythmia or like ventricular premature complexes. Any new onset bundle branch block, if they ask and say, that it be indicative of myocardial ischemia only in the perioperative setting. Okay. And
even RVV, even right bundle branch, no?
Right ventricle can be a non-specific one, but a new onset RBB should poke you, because that was not there before, and it is evolving in the interim perioperative period only. That is why. And that's so. And in the perioperative sinus tachycardia causes, circulatory embolus we should not forget, and anaphylaxis. These are the two most common things we'll forget. We'll always say pain, hypovolemia, anemia, inadequate depth, patient and procedure related factors we'll say, because laparoscopy, sympathetic surge, tachycardia, hypertension. But circulatory embolus and anaphylaxis are two things which we'll easily forget. Okay. Okay. Anyone wants to try this? I thought the session will get over by 9:30, but then it's still going. So if it is okay for you to continue, we'll continue few more examples of perioperative
This ECG is showing tachycardia with
It's SVT.
broad complexes.
Yes.
Sorry, narrow complex.
Narrow complex. Yes, it's narrow complex.
Yeah, narrow complex. So it's without P-wave. So it's in run of SVT. And
Yes.
along with there is a ST depression in the inferior leads and also the chest leads. The patient may be having a supraventricular tachycardia with the MI.
Yes. Yeah, then the pulse rate is somewhere
stable.
and hemodynamically stable. So what's your treatment you have planned for?
Adenosine.
Adenosine. Adenosine. Vagal maneuvers and adenosine. Hence, like one can say vagal maneuvers as well. So
yes.
Yeah. Wait. So just a second.
Can you share your PPTs on the group? After
Yeah. This one I made for some other presentation, but then I just got into it. This is an interesting one. Please
this
read
is
the
prolonged
history.
QT interval. 23 years old.
Read the history and correlate it with the clinical scenario and the ECG. So what's your treatment?
23 years old female posted for laparoscopic umbilical hernia repair, given ondansetron 4 mg IV bolus, and he is hemodynamically stable.
Prolonged QT interval?
Yes.
Long QT syndrome?
Long QT syndrome or prolonged QT interval?
It's a prolonged QT interval because of ondansetron.
Ondansetron,
No, just a second. Yeah, just a second. No, this my screen like Russian slideshow. Yes, I mean I was not in the slideshow. Is it? I'm not aware. Just a second. Just wait. I'll just share the screen again. Yeah. So what is this rhythm? Anyone? So this is like
Broad complex tachycardia.
No. This has become like, this is VT, right?
Yeah, broad complex. Yeah, VT. Yeah, broad complex tachycardia, VT.
And the rhythm here, the VT morphology here is different from here.
So polymorphic
It's
VT.
a polymorphic VT. So what has triggered it? It is any drug which causes QT prolongation, precipitates polymorphic VT or R-on-T phenomenon. So ondansetron, which prolongs the QT, has precipitated this polymorphic tachycardia. So he's hemodynamically stable. So what's your treatment of choice?
Magnesium sulfate?
Yes. Magnesium dose?
2 gram IV, 2 gram IV stat.
2 gram IV bolus. So since it's hemodynamically stable, it's 2 gram IV bolus. Yes. And I'll share 1 minute. Yes. This is again an interesting ECG. So this they may not ask in the exam, but still it may come. He's a 74-year-old male patient. He's a known COPD, undergoing open cholecystectomy under a pure epidural. Upon giving epidural boluses of say 10 ml of 0.5 bupivacaine, hypotension happened. And for hypotension, they have given ephedrine. And the patient developed this rhythm. I'll just zoom on the. This is actually multifocal atrial tachycardia because the morphology of P-wave will keep varying and it is like an irregular rhythm. Okay, we may not be exactly finding out, but still P-waves are still there.
Yeah, somewhere there, somewhere missing.
Yeah, somewhere missing. And the morphology will keep changing. See, it has changed here. And in the V1, we can find it very easily. Here, the P-wave is different. Here, the P-wave is different. Here, the P-wave is different. So everywhere the P-wave morphology, at least more than 3, this thing should be there. Morphological abnormality of the P-wave should be there to say it is a multifocal atrial tachycardia. So Actually, any COPD patient in whom we are giving a sympathomimetic can trigger an atrial dysarrhythmia. So in this, if at all the patient had an hypotension, a phenylephrine or a pure alpha agonist would have been a better choice than a sympathomimetic which has a beta action. This patient actually I encountered in a real life scenario. That is why I keep telling this patient in all the perioperative arrhythmias cases whichever I take. So how would you manage? He's hemodynamically unstable. So how will you manage? Because we have given ephedrine 6 milligrams bolus and because of hypotension only. And after giving phenylephrine, if the BP improved or not improved, if the patient is hemodynamically unstable, you will again treat it as like any arrhythmias which is unstable. Okay.
Yep.
Since it is an atrial arrhythmia, we can go on cardiovert this patient. Yes. You can cardiovert this patient as you will do for an AF. And then if it is like, it should do. If you cardiovert, it should do. Okay.
Yes, sir.
Okay. So we'll always forget the call for help. And as all you have mentioned, any arrhythmias, if they ask you say about adequate oxygenation, assess the airways, and circulatory reassessment and ventilator parameters and all that. So this also is it's a real life scenario only. So what is this and how the patient is in an endoscopy suit and how will you manage? The patient developed this rhythm, hemodynamically again still stable.
It is a VT again.
Yes.
With
yes.
hemodynamically stable. So pharmacologically we'll start. We'll give amiodarone.
Yes. Yes. Okay.
150
what
mg.
is the rhythm? Who has asked about what is the rhythm? Which question I forgot. So is it a multifocal atrial tachycardia question? This is someone has asked me what is the rhythm. So this is polymorphic ventricular tachycardia, and they may ask about what are the perioperative drugs which can prolong the QT. So ondansetron is one, haloperidol is other. So this is a polymorphic VT. This is a multifocal atrial tachycardia. Okay. So this obviously is a VT. Okay. Any other doubts or questions you want to clarify or ask? So this is for, so any perioperative bradycardia, if they ask, you always say atropine 1 milligram bolus up to a maximum of 3 milligrams. Then you can keep dopamine or adrenaline infusion. Whatever they ask now, say the ACLS guidelines. They're okay with the ACLS guidelines. When they told, they accepted. When I told, they accepted. Is that fine?
Yes.
Okay. Okay. So that's all for today. If there is any doubt or any clarification you want to ask, kindly put it in the group. We'll be happy to answer.
Thank you.
Okay. Thank you. Thank you all.
Thank you, ma'am.
Thank you.
Thank you, ma'am.
Thank you.
All.